Miss Tubbs passed her weaning trial and is extubated to a nasal cannula at 2 liters per minute, but almost immediately she became tachypnic and her SpO2 decreased to 82%. I assessed Miss Tubbs and believe she is performing rapid shallow breathing, and I collected an arterial blood gas. The arterial blood gas values were a pH of 7.3, a PaCO2 of 85, her bicarb was 43, and her PaO2 was 50 due to her rapid shallow breathing. I shared my findings with Dr. Nose, and it has been decided that Mrs. Tubbs needed immediate BiPAP therapy to assist her spontaneous breathing efforts. To size Miss Tubbs with a mask, I used the packaging had a template for mask sizes of small, medium, and large. Due to her small face, I decided it was best to go with the small mask. I secured it to her head using the head straps or the headgear, and I adjusted the mask so we had a good seal to prevent a large leak. So she gets the adequate ventilation she needs. The things I took into consideration before choosing the full face mask, I thought about the nasal mask. And the nasal mask works best for someone who may be claustrophobic. And there's also a better chance of not having a large leak with a nasal mask because it is smaller. But the problem with the nasal mask is it's not recommended for a mouth breather, which Miss Tubbs is definitely a mouth breather, or for people who are requiring higher pressures for the BiPAP. So I decided that it would be best to go with the full face masks for Mrs. Tubbs. The initial BiPAP settings I recommended to Dr. Nose to start Miss Tubbs on was an IPAP of 14, an EPAP of 7 centimeters of water pressure, a set rate of 13, an FiO2 of 35%. IPAP helps with ventilation to decrease Mrs. Tubbs' CO2, and the EPAP helps with oxygenation to get her oxygen levels back where they need to be. And the respiratory time I set for her was 1.5 seconds. And the rise time I set for her was a rise time of 0.1 seconds. The initial alarm settings I selected to use was a high pressure alarm at 19 centimeters of water pressure. The low pressure, which is also called the low P, I used 12 centimeters of water. And the low P delay I put at 20 seconds. The apnea is also always going to be at 20 seconds. And the high respiratory rate, I set that at 30 breaths per minute. To monitor the efficiency of Mrs. Tubbs' BiPAP therapy, I'm going to check her oxygenation and her ventilation status via transcutaneous monitoring, as well as redraw an arterial blood gas in about 30 minutes of her being on the BiPAP. I'm also going to watch and see how she responds to the treatment. I'm hoping that with the BiPAP, her tachypnea will subside, and her work of breathing will decrease. I'm also going to make appropriate changes to her BiPAP settings depending on how she responds to treatment.